So this is going to be the pediatric EMS cases, because I know that's something that you've got to have in your continuing education. But if you guys can think of any cases, or you come up with anything during this talk, this is a little bit different than our usual. I'm going to intersperse the talk today with some audio from Denver Health. But we're going to have real cases too. So this is a 7-year-old who EMS is activated for, oh, yeah, I forgot. Is all that working?
Yeah, we're recording.
Wow. Is this going to go viral on YouTube?
YouTube, it is.
They had that on the podium and I moved it.
It'll work there, it's fine.
Whoa. Can you monetize this too if it goes like millions and
Sure,
bucks?
why not?
All right, so
We'll send it to the foundation.
EMS is called for a 7-year-old, increased work of breathing. He has a known allergy to peanuts, and he got his symptoms after eating a birthday cake at a friend's party. His mom's on scene, and she already gave him his first IM injection with an EpiPen, a junior EpiPen. And the first EMTs get there and note that he's still got some wheezing. So the initial exam, heart rate of 140. I'll just stop there for a second. You guys have a pretty good idea of normal ranges for pediatric heart rates. It's sometimes it's harder the younger you get, but a 7-year-old, that's fine.
He's also had epi.
And he's had epi, right? Blood pressure of 85/60, and generally speaking, the 50th percentile for blood pressure, a rough and easy way that I remember it is 80 plus 2 times the age in years. So that's about average. So he's below that. 80 plus 15 would be, 14 would be 95. The 5 percentile is 70 plus 2 times the age in years. So he's right at the bottom level of normal, or he's actually frankly hypertensive. Respiratory rate of 40, and he's on a non-rebreather. They get a SAT of 98%. He's got a generalized rash, not a good sign. He has no facial or airway edema, which we can be thankful for. But he does have audible wheezing, and when you take off his shirt, you can see that he's pulling on his ribs pretty good. And his mother, of course, is distraught. So, what would you do next? Just based on this. This isn't very complete. Albuterol. So try to reduce the work of breathing.
Get the Benadryl on board.
Benadryl. So some kind of antihistamine. So how would you administer the Benadryl? IM. Yeah, it used to be I would wait around and do an IV for these kinds of things in the ER, but I think a good hefty dose of IM Benadryl is as fast or faster than an IV, especially if you miss the IV on the first shot. You're really behind the gun here for time, and you can always give another dose of Benadryl IV once you get an IV in.
I think considering we're at the 10 minutes from the first epi, so
Yeah.
we considering possibly a second.
And that is really the main reason I put this in, is because when we give epi, we always get a little bit apprehensive. What's going to happen? Is it going to be the bad case of epi? And I think probably collectively in this room, we've given a lot of epi to people that are alive. I'm not talking about the cardiac arrests. We've given tons of epi to everybody. But for live people in extremis, epinephrine generally is well tolerated. The one thing that we were taught in medical school and residency is if you give it to someone who's too old, you might precipitate a cardiac dysrhythmia like VFib, or precipitate some kind of coronary spasm and cause that person to have an MI. I've never seen that in my practice, and I've given epi. It used to be, before we had really great things for asthma, epi was first line for status asthmaticus. Well, actually, it wasn't even status asthmaticus. You just had a really bad asthmatic tack, and you start the albuterol and you give a shot of epi, just like anaphylaxis. And I remember a case some years ago when I gave, I think it was an 84-year-old woman with asthma, a shot of epinephrine. And I think I had more tachycardia than she did, because I gave it to her and I just sat there and held her hand and hoped that she wouldn't die. And this was in an ER where we didn't have a lot of bed space, so we had this one room for the asthmatics, which was way off in a dark corner, and they had like 15 of these chairs that were set up, and there were very few people back there. You couldn't really call for help because it was a closed area. So I brought all my stuff back there, gave her an injection, and there wasn't even a monitor. So I sat there, held her hand, and in less than 5 minutes, she said, "I can breathe again." It was amazing. And she'd had, I think, 3 albuterols, a couple of Duonebs, IV Solumedrol. She'd had the works, and it was the epi that broke her.
In that case, would you sit in your hands a little bit where he doesn't have the airway swelling that you're concerned about? As far as giving the second dose of epi, would you just see what the Benadryl and albuterol did, or would you?
I think it could go either way. In this case, the medics made the call to give another epi right away. And I want you just to feel comfortable with that. If you get to this position, even without facial or airway edema, but the vital signs are soft, he's got a generalized rash. Peanut allergy generally is a bad one. If somebody says peanut allergy to me, that's a lot worse than most other allergies that you see to foods. However, in the ER, about half the time I wait and I see what happens with the Benadryl and all the other stuff. But I always have the epi ready. So I think you guys got everything. Yeah, repeat epinephrine. And the dosing of epinephrine in your protocols, well, do you guys still, do you just carry the EpiPens and the EpiJuniors, or do you now dose it?
Dose it.
Yeah, because it's a lot cheaper to buy it that way, and it actually makes more sense to me that you actually can control the dose and you know exactly what's going in. So does anybody here remember what a dose is by kilogram? 0.05 to 0.1, I think, milligrams per kilogram. Nope, I'm wrong. 0.01 milligrams per kilogram. This kid was about 50 pounds, so that comes out to 23 kilograms. So this is something I know what it is for an adult, because you just know what the standard dose is. But when you get the peds, you're dealing with a little bit more calculation. And
Just keep it at the 0.15, we do the half dose.
you can do a half dose. But I want you to remember that you've got your handy app here, which I love. And it's constantly updated, so I just plugged in 50 pounds, which converted to kilograms for me right away. And for, I think epinephrine's the second one up there. And it tells you right there 0.23, round that to 0.2. But it's a little bit more than he got. It probably isn't clinically meaningful, the difference between 0.15 and 0.2. Volume is important, and I put that in there because if you remember, the reason why people crash when they have anaphylaxis is because when histamine is released systemically into your bloodstream, it's a chemical, it's a very small chemical, and it has a geometric shape that's very much like the antihistamines, which is why antihistamines work. They lock into the same receptors in your tissues, but instead of opening the receptor and telling it to do its programming, the antihistamines, when they lock into it, they block the receptor from turning on. So if you look at the organic spatial representation of Benadryl, it's a little bit larger than histamine, but it has a very similar shape, and it's the shape, the geometric shape, that lets it actually target histamine receptors in tissues. So the primary receptor in vascular tissues that locks onto histamine targets causes the smooth muscle cells of the blood vessels are interlocked. They're like this. And if they're locked tightly enough, nothing leaks out of them. When you get histamine to target a capillary bed those muscles shrink back a little bit and they open these spaces. It really just looks exactly like this. And what happens is the blood cells, which are maybe about this size compared to what I'm doing, they stay inside the circulation, they don't go out, but all the water, all the serum, all the liquid part of the blood just leaks right out. And because of that, you don't have intravascular volume, and that's why your blood pressure drops. Then you lose oxygenation to the vital organs like the heart, the brain, the kidneys, all the things that you need to preserve basic life. So, and that happens very, very fast, and it's not something that happens to everybody. You can give volunteers shots of histamine to see what they do. This is actually something that medical students have to go through sometimes for research. And not very many of them will have an out-and-out anaphylactic reaction. But the few that do have profound reactions. And epinephrine, for some reason, it doesn't lock into the histamine receptors, but it targets other receptors in the same smooth muscle matrix of these vascular structures. And it just causes them to tighten back up nearly instantly. So the effect of epinephrine is to stop leakage, but if you've got somebody who's already hypotensive and they've lost a lot of intravascular volume because all the water in their blood has leaked out, and that's the reason why you look for facial edema and total body swelling. But it can happen so fast without even seeing that, you can just have somebody go into cardiovascular collapse. So if you've got lines, just run in the saline, because that gives you a little bit of temporary volume sustenance while you're trying to get the spaces to close up with drugs. And it's the same bolus formula for adults, 20 milligrams per kilogram. That comes out to about half a liter. And this is something that I usually, we spend a lot of time when we do pediatrics calculating maintenance and volume replenishment. But in our line of work, you really titrate to effect. So if you know that 500 cc's is safe for this kid, you can run it in as fast as you want. And if the kid's still okay or not okay and looks like he needs more, you can give it again. Just like we do 2 liters, and then if the person's still in shock, you just keep going. It's not until you get, for an adult, into maybe 5 or 6 liter ranges when you're doing resuscitations that you start to worry about how you're going to offload that volume. But I've been involved in cases, resuscitations, where like a healthy 5'7" electrician got 10 liters of fluid in 10 minutes. And in that period of time, his legs and his arms and his face swelled up. Fortunately, he was already intubated, because it would have been really tough to get the tube in around all that swelling. But the guy survived, and he needed the volume. And the critical care people later said, we can deal with the extra volume. We've got ways of taking that off. But if he doesn't have blood corpuscles that can transport oxygen around from his lungs through his heart into his brain, he won't be here. And that's really kind of like a sledgehammer therapy to get that to happen, but in that particular case it worked. So we talked about reducing the work of breathing, and a lot of times when kids have allergic reactions, you give them the epi and the albuterol, sometimes with a little ipratropium. I don't even know why they ask you to put the ipratropium in. It's the albuterol that really does the work. Makes things a lot easier. Does anybody know the answer to this? How much albuterol is too much? First of all, I'll leave you with an interesting fact. Albuterol is not FDA approved for use in pediatrics. That shocked me when I first heard it. So why are we using it? And it's because the law and the politics and the regulatory environment around use of medications for kids is much different than a lawyer would think. Almost all of the medications that we have that are FDA approved go through this rigorous process where they've got to be tested for safety, and then they've got to be tested for efficacy. And that's done in multiple stages by the FDA in these things that we call phase 1, 2, and 3 human trials. So when a company applies to the FDA for permission to market its medication for, say, high blood pressure, they've got to tell the FDA that we're going to spend this amount of money over this period of time and enroll this many patients in phase 1, 2, and 3 trials to see if there's, first of all, if it's safe, and then secondly, if it works, and then there's usually a polishing trial that just says, okay, we double-checked everything and it works. And it costs millions of dollars. Drug companies always complain that it's too much money. And the FDA says, okay, this medication now is something that you can advertise as FDA approved for hypertension. Albuterol went through that process, but for adults. And I think actually the studies may have only done male adults with asthma. So it was a very limited kind of thing. They spent the money, they got FDA approval for use as an anti-asthmatic in adults. The problem is it costs just as much money to do the same sort of FDA approval process for kids. And most companies just say, well, if we just get it out there and pediatricians start using it off-label and it works and it's proven to be safe, we can skip the FDA approval process as long as it's in common use and it's accepted on a widespread level. It passes muster. And that doesn't apply to all off-label uses. You'll hear that term. If you can take, I could take, well, I had this crazy colleague in this one hospital I worked in who thought vitamin C, intravenous vitamin C, could bring somebody back from cardiac arrest. And he actually came into a code once, and it was futile. I mean, the guy was long gone. And the nurses said, Dr. Smith is here, and he's got something that you've never seen before that's going to blow your mind. And I said, whatever he wants to try is fine with me. And the guy whips out this vial of vitamin C and injects it in the central line I put in and says, you just watch, he's going to wake up. And I was like, okay. I mean, if he does, wow, I'm going to be really happy. I think it was the right thing to say. It was dramatic. And of course, the guy didn't wake up. That's off-label use. That's not really something that I think anybody would approve of. And if he actually, were taken to task for that, it could be his license. But if there was research that showed that vitamin C was good for certain types of dysrhythmias, and it was used based on the research that's not part of the FDA trials, that kind of off-label use is permitted. So albuterol was tested in many, many different pediatric trials that were not sponsored or part of the FDA approval processes. And once it reached that status, pediatricians and emergency physicians and EMTs could use albuterol in kids off-label, but with the permission of all the regulatory bodies. So that's just a weird aside. The answer to the question, how much albuterol is too much, is it's really, really tough to overdose somebody on albuterol. Some of the trials that I've read with young volunteers would give MDIs basically every 2 minutes until either they ran out or they experienced side effects that were too much. And some of these studies would go into the 50 or 70 or 100 MDI dose range before they either stopped or the volunteer said, I think I'm going to stop because I feel too jittery. And tachycardia was one of the adverse effects that you know, but nobody had a dysrhythmia or a cardiac arrest or any other meaningful, long-lasting outcome. So the reason I say that is if you've got somebody with a bad wheeze from asthma, status asthmaticus, or anaphylaxis, feel free. It's much safer than epinephrine. You can just give albuterol constantly. In fact, one of the things that we do in the year, one of the orders that I am able to write is continuous albuterol neb, which means don't stop it ever until I tell you to. And sometimes I'll run it for 2 hours, and sometimes it works. But rarely have I ever seen anybody say, no, that's too much. And then we've got the immune modulators, which include Benadryl, which is dosed, the starting dose, a good starting dose of 1 to 2 milligrams per kilogram. That's either IV or IM. If you're out in the woods and you're allergic to bees and you get stung by a bee and you happen to be carrying Benadryl with you, it's something I tell some of my patients is take the oral Benadryl if you don't have the injectable and chew it up. So you powder. You want it to get into your system as quickly as possible, and you can aid digestion just by getting into the finest powdery form, and then drink it with something like warm water, something that will carry it in and get it digested and across the intestinal mucosa as fast as possible. But like I said, an IV dose or an IM dose, if you give it fast, is about the same onset. And if it doesn't work right away, you can repeat it once, twice. You can give, I think in some cases, my initial dose for a normal size adult who's got anaphylaxis is 100 milligrams IM. If they come in while we're getting things set up, Epi's going in, 100 milligrams IM Benadryl, and a lot of these people feel a lot better, but then go to sleep. Does anybody else here have strong reactions to Benadryl, like me?
I get peeled off the ceiling.
So you go crazy.
Opposite.
Yeah.
Yep.
I just go into a coma. And it's pleasant, but I'm non-functional for a day, no matter what dose I take. I don't know why that is. Methylprednisolone, which is Solumedrol. You guys are, is that your
Dexamethasone,
protocol? I didn't think, yeah.
Dexamethasone.
Dexamethasone now,
Yeah.
right? Yeah. So you can get dexamethasone in the equivalent. And something, I'd have to look it up on that thing, but it's going to be somewhere in the several milligram range. Okay, so what happens next? Uh-oh. He says he feels dizzy. So you give a lot of interventions. His repeat blood pressure is really bad.
His respiratory rate's increased.
His respiratory rate is increased. So this is in there because all of the things that you just did are things that you can repeat. You can do the epinephrine again, you can do the volume again, you can give more albuterol, you can give more Benadryl, even more dexamethasone. In the ER, at this point, everybody says start an epi infusion. And the principal research for the epinephrine infusion actually came from Australia because there are a lot of poisonous, venomous animals in Australia. Some of them are horribly venomous, and they have quite a few really great anti-venoms that are in use for these types of bites. But because of the way they're manufactured, primarily in the past they were made from horse serum. So you take a poor horse and you find a bunch of coral snakes and you just get them to bite the horse or somehow inject the horse full of the venom, and you give doses that you knew wouldn't kill the horse but make them pretty miserable. And then after a few months, you know there's antibodies that the horse has developed against the particular venoms. And in some cases, you wouldn't do it with one species. You take like 5 different types of poisonous creatures and you just subject this poor horse to all of these bites, and then you get in the serum, which is the liquid part of the blood, antibodies against a lot of different things. So you get this super expensive horse now, and you'd be able to bleed them every once in a while, pull off the liquid part, and sell it for like $1,000 a dose for any number of different types of venomation toxicities. The problem is that we don't really react too well when you inject horse blood into your circulation. It's just like you get like a blood transfusion reaction. And in many cases, it is something which can precipitate a full-blown anaphylactic reaction. In fact, it's more than 50% of kids who get these infusions of the antivenoms that become anaphylactic. So in Australia, when you set up, I think some of the venoms, the antivenoms have improved in their recombinant DNAs now, but most of the time when you set up to do a horse antivenom treatment in the ER in Australia, at the same time that you're getting the stuff set up for the antivenom to go in, you're setting up an epinephrine drip. And in some places, they turn the epinephrine drip on before there's even a reaction because it's so common to get these reactions. And you can manage them. So the kid starts to feel woozy, starts to blush a little bit, the blood pressure goes down, you turn the epinephrine drip up, and you just titrate it to effect, and you run it for, it sometimes goes on for hours or even a day by the time you get the whole infusion of the antivenom in. So it's a really interesting science that developed from some weird background. But epi infusions are things that you're not going to use in the ambulance, but it's something which you may see if you're transferring somebody from one of our hospitals here to Portland, and they're having a really bad anaphylactic reaction. Uh-oh. This case just gets worse. Yeah, okay, so now he's having some respiratory issues. His pulse is up higher, his respiratory rate's up higher, his SAT's starting to drop. He's starting to complain of the facial swelling and tongue sensations. So, of course, you're going to prepare for intubation. And this is something which really makes any physician, not just EMTs, but anybody dealing with this kind of thing, pucker up, because you know it's going to be a difficult intubation. You know there's no respiratory reserve because this kid's already deoxygenated, so you can't pre-oxygenate. You know if you make a mistake and you don't do it right, they're going to brady down. That's what kids do, and then you're really, really screwed. So one of the things that I would do in the ER is make sure I had all my alternative airway stuff set up and ready to go. The other thing that's really important that we talk about a lot in on the physician side of this kind of case is whether or not to use drugs, and if so, what kind. And the reason I put this in, because when you guys are intubating, usually it's somebody who you're just intubating. Do they have, for the medics, is there a protocol to use any kind of drugs? It used to be that there was some Versed, and at some point they were talking about using succinylcholine, but no, it's just, you just have to ram the tube
Yeah,
down.
that's a post-intubation.
What's that?
I think if anything, it's post-intubation, and we can't RSI or anything.
Right.
Not even close.
Has that ever been talked about as far as you know at the state level?
They've been
been
discussing
discussed.
it.
Yeah.
But they're having issues with a lot of innovation, unsuccessful innovations in the first place, that
Yeah.
they didn't want people dropping
Something
The high-
and not being able to.
the high-risk, low-frequency things.
Yeah, that makes sense to me. That debate has gone back and forth. I grew up in Seattle, and there were a lot of intubations, and RSI was used in the field before we had it in the hospital, which is kind of backwards, but really great. But in a lot of other systems, because you just have to intubate repeatedly to keep that skill, it's tough. So we're trying to focus, it's kind of like ACOS, you're just trying to focus on the things that really matter. Get really good at those, and then maybe we can add on some of the other things if we need to. But as far as drugs go, in the case of pediatric intubation, they're critical. And the reason is there are different reflexes, or there are more prominent reflexes in the pediatric airway. So when you gag a kid, it's much more likely that you'll make the kid vomit or make them brady down. If you give succinylcholine, one of the side effects of succinylcholine that we rarely see in adults is bradycardia and sometimes asystole, which I've seen a few times because that's just one of the reflexes that happens. So as a result, the guidelines for intubation of kids involve actually more drugs than we would give than we would for regular adult intubations, including the use of some what we call anti-sialagogues to dry the mouth, some things that reduce the reflex of gagging, and atropine, generally up front to reduce the chance that the kid's going to brady down. So you got to have all those things lined up, and it's even more complicated because if you're talking about a kid who's not a full-grown adult size, then you got to calculate what the dose is, and then you've got all these syringes laid out with different drugs in them, and you got to make sure you give them in the right sequence and they're the right dose. So a lot of bad stuff can happen because you don't get all that straight in a really chaotic situation where you really just got a few moments to get the tube in. This is another option, which may be something that you'd see or be able to do sometime, but you can, just like you shoot epinephrine down an ET tube, where we used to, it still works. We used to also inject it intracardiac, which still works. But nebulized epinephrine works really great.
Yes, it does.
And it's really the same exact thing as what we call racemic epinephrine, which you give to kids with croup. And you know, every croup season, we line kids up in the ER and we give them all racemic epinephrine, which is really a fancy way of saying give them a nebulized epinephrine. Racemic epinephrine, if you remember way back to some kind of chemistry that you had, all molecules come in a left-handed form and a right-handed form. So they look the same in real life, but they're mirror images. And in some research, way back in the dark ages, somebody came up with this idea that I think it's the L isomer, the left isomer, I can't even remember which one it is. I think it's a left-handed one, of epinephrine worked better for kids with croup than the other isomer. So they went through this whole manufacturing patenting process of getting this one company to just give you these little liquid vials which just had the left-handed version of epinephrine in it at like triple the cost, of course, and they said it was better for you. It turns out there's probably no difference at all. It was just like some marketing scam that somebody came up with so they get a patent and say, and now to this day I still walk in, so okay, let's do a racemic epinephrine. They go look for the little special vial and they draw it out carefully. You know, it's kept in the vault. In actuality, if we just took out our regular old epinephrine and squirted a little bit into the nebulizer and filled it with saline, it'd be the same thing. And you can give a lot. So the dose, which is a little mind-boggling, is 0.5 milligram per kilogram. But because this kid's 23 kilograms, that'd be 10 milligrams. So there's a maximum cutoff there. We just say, well, 5 seems like a lot. Let's just stop at 5 and see how he does. But that's kind of a typical dose for a kid with croup, 2.5 to 5 milligrams over 20 minutes. And you walk back in and they usually look better. You can give epinephrine IV, and that's really basically the same thing as giving it by infusion. The problem with the infusion and IV use of epinephrine is that epinephrine is usually provided to you in a bottle that says the concentration is 1 to 1,000 or 1 to 10,000. They don't say how many milligrams per cc. You've got to calculate that. You've got to understand that 1 in 1,000 means 1 milligram per cc. And 1 in 10,000 means 1/10 of a milligram per cc. See, it still gets me. And in the past, because of that designation, people have given 10 times more epinephrine than they should have, and they've hurt a lot of people. So this is something that's pounded into our brains when we do these training sessions, is make sure that you understand how much epinephrine you're giving in an infusion, because it's very, very likely you're going to get it wrong the first time. So have 2 or 3 other people check you. And even if you have 2 or 3 other people check you, we can tell you about all these cases where everybody got it wrong. And to demonstrate that, the slide here originally had the IV epinephrine. In the way that it's published for dosing, it's micrograms per kilogram. And a microgram is 1,000th of a milligram. So I translated microgram to milligram so that we're all using the same unit. But you can see, how do you measure 0.0001 milligrams? There's no way. So then what you've got to do is you've got to dilute it so it's 1 to 10,000, so you've got more volume, and you multiply everything by 10, and then you see where this is going. It's really, really important to keep it right on track.
Calling the doc at 3 o'clock in the morning.
Yeah, in most cases, when we get to this point, we have a pharmacist come down and double check everything, because they're the ones that are, paid to make sure that you don't make these mistakes. Okay, here's where it goes bad. So he begins making high-pitched respiratory noise and struggles to breathe, and then boom, he stops breathing.
Oh, we know how to fix that.
Because of laryngospasm. So this is where we kind of started when Derek was saying, well, he doesn't have facial edema or stridor. When you see that initially, that's like full-blown anaphylaxis, and that's the thing that will kill somebody immediately because they can't breathe. The other thing that usually gets them within a few minutes if they're in full-blown anaphylaxis is just cardiovascular collapse from all of those, all the liquid leaking out of their bloodstream, basically. So, laryngospasm in anaphylaxis is due to one of 2 things. We have always been taught that the worst case scenario is where the airway is so swelled up that it just closes off. There's no hole left. And that does happen. I've seen that a couple of times, and it's really, really difficult to work around it. You just can't intubate. You have to do a surgical airway. There's just no other alternative. But the other reason for laryngospasm is a protective reflex where your epiglottis, which is that kind of cartilaginous flap that you see when you put the laryngoscope in and you lift up to see the vocal cord. So it's a flap that kind of looks, it's curved like a duck's bill, and it lays way back there, and its job is to flap itself down over the vocal cords and seal the airway if you're choking. The primary example of that is drowning victims. The first breath of water that most people take when they're drowning causes laryngospasm, and it's just a reflex that we have built into our bodies where that flap just goes bump, seals off the airway so you can't inhale the water, and you end up swallowing the water instead. So you've got two tubes. You've got the trachea, which is the one that's air-filled that brings air to your lungs, and right behind it you've got the flappy, collapsible esophagus, and the epiglottis lays between them. So most of the time when I've seen laryngospasm clinically, it's been when the second variant has happened, when that flap goes down. And a prime example, and hopefully this won't appear on YouTube in too many places because I don't want my wife to hear that I'm telling the story. But when we were first married and living in the middle of the sticks, as some of you know how we live, at dinner time one night late after, there's no way of getting any help anywhere, my wife swallowed an olive. And I was just like in my nice, dinner time state, and I was relaxed. I was finally not thinking about anything medical, and all of a sudden she stands up, turns blue, and goes, and grabs her throat, the universal choking sign. So I gave her the Heimlich about 5 times, nothing happened, and she starts like running away from me, turning blue, holding her neck. So I go to the drawer, and I pull out, the steak knife, and I'm like, ready, okay, I know this is something I have trained for, I can do it. And she looks at me, and she finally gets a breath in, and she's like, don't do it. And she holds up the olive in her other hand. I'm like, hold it. I thought that olive was inside, you're choking on it. So she convinced me not to cut her open. And about 10 minutes later, and she's writing down like things, don't cut me, as she's what I think is choking. What happened, what I learned about her that night is that she has a laryngospastic reflex to vinegar. And the olive, which was in brine, just set it off. So she, I saw her, it looked like she inhaled the olive, but she popped it out, and it wasn't until I got the knife out that she showed me that the olive was intact. But it was the vinegar that caused laryngospasm. Yeah. So it's really tough for me now to tell if she's choking or she's having laryngospasm because she loves salad with vinegar. She loves olives. She's like, anything that's got vinegar in it, she just like goes and gets it. And then I've got to just get ready and not do anything. So in this case, there are a couple of maneuvers. You got a bag valve, of course. You got to get air in. If you can, you intubate. You just bypass the whole structure, get a tube past it. But there is one other technique that I want to show you guys today, which is new to me too. In doing the research for this, I was amazed. Larson is a doctor who is an anesthesiologist who discovered in his own practice, because he was a pediatric anesthesiologist, so he did a lot of intubations on kids and young adults. But he discovered this maneuver, which started out as a jaw thrust, which we all know and love. You take the jaw, you push it forward, the tongue comes forward so it's not laying on the airway, and a lot of times you open an airway. He found that if you put a little bit more force, so you're actually feeling the notch at the very top of the mandible. So the mandible comes up here, and right behind your ear there's kind of a depression. It's very prominent if you feel that. if you stick your thumbs in there and you push in, it hurts. So he said, you gotta push your thumbs in till it's gonna hurt somebody, whether they're awake or not, and then you push forward. The noxious stimuli from the pain or whatever it is that he's doing by pushing and digging his thumb in there, along with the jaw thrust, he said relieves almost every single case of laryngospasm that he's ever come across. So of course, I've been waiting for my wife to eat another olive. Ever since I discovered this, I've been putting them out all over the place, hoping she'll do it. Because I want to test this out, and I didn't have a chance. I couldn't tempt her enough to bring you the news. But as soon as I figure out if this works, then I'll come back and do a report, because I've got the perfect lab. And he wrote this up, and it's actually been adopted by some pediatric critical care things. It's part of some teaching now, and I just love to see if it really works. Okay, so that is our anaphylactic case with some interesting highlights. So the next thing I'm going to do is, if I can figure out how to do this, I'm going to play, these are pediatric med control calls from Denver General that they picked because of some teaching element in them. And I thought they were kind of interesting to listen to, so let's see if I can figure out how to do this.
Can you hear me okay? Yep. Okay, I just had another long walkout. Right now I've got 2 absolute criticals and 2 with central ones for total 4. I only have 3 ambulances, so you can either get the 2 sick ones and the 2 minors, or you can take all 4. I think take the 2 sick ones and 2 minors, or just the 2 sick ones. Well, then you take 4. They're minor shot. I got one that's got a groin shot and one that's got a kidney shot. But they're both awake and talking. 1 groin, 1 kidney. These are the minor ones. Both awake and talking. The other 2 are critical. So we got 2 critical. We'll take the 2 critical, of course. Okay. 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 Is one of them are these 2 criticals arrest yet, or what? No, one of them's arrest. One of them is not arrest. He's still talking. When you sing, you don't get my guy out. Okay. 1 arrest and 1 critical. And then 2 minor. Bring all 4. Bring all 4. You gonna take all 4? Yep. Okay, they're all gonna be in front room. You got that? Okay, cool. Bye.
So obviously a high tension scene. This is a gang shooting. Multiple patients, all pediatric patients, are all like in their teens. And I thought, so any comments about that call? Is that the kind of call, is that information that he provided what you would have provided? Is there anything that you think he should have said differently? Are there any other important points? Or there?
I would have relayed what my patients were, at least with a guess of the ages, so that
Yeah.
you would have pediatric on standby
Yeah.
and whatever else you might need.
Yeah, communicating age is important because a lot of times what we set up to do is much different. You're right. You're right. Generally speaking, I thought that was a good call, and one of the things that we all are supposed to take I've taken it probably 4 times, a med control online course, radio protocol, and I think you guys have to go through some kind of similar training. But when you're calling to pass information from the field to the hospital or to another provider, just remember that what you're trying to communicate is whatever it takes to enhance the patient's care. I've been in situations where I've talked to a medic. Usually these are volunteer departments who will go on for half an hour and tell me everything about the patient. But what I really want to know is what room should I put them in, and do I need to have respiratory standing by, or do I have to have any other special equipment? That's it. Oh, and how long is it going to take you to get here, so I can know how long it's going to be to set up. I mean, that's essentially my decision-making process. So when you hear these calls, just think, are they communicating the most effective thing? So this is a chaotic scene. Obviously, a lot of shit's going down fast. There's a person who's already dead, who might be salvageable. They're trying to figure out where he's going to go. So I think this medic was just trying to concentrate on,
Can you
can I tell this guy to drive, and where is he going? And, you know, and are you gonna be ready on that end? And I think he did that okay. So let's see what we got here. Oh, there's a couple of other things that I thought were interesting background. So in this case, the shooter was still on the scene, which puts you guys at risk. The physician was really, I think, not thinking in terms of what can I do to help the EMTs like be safe. He was just trying to figure out if he could take 4 patients or 2 patients and where they might go. But that's a concern that he might have been able to help better with. Provide the number of injured patients and their acuity. I think he did that pretty well. This is important in our area. Understand the community hospital capabilities. So I know if we got that call in Miles right now, it would really depend on who was on and their comfort level with a mass casualty incident. I'd have no trouble taking 4 people, but I know that we were limited, and it might even be sensible to consider triaging so that the less critical people would get life flighted. That would offload us immediately. We could concentrate on stopping bleeding, salvaging somebody who couldn't survive a flight, and then re-life flighting them later. Or some weird scenario that's way out of the box. But I think you guys are really good at this because you know all the hospitals and what we can do around here. So this is not a traditional call where you call in and you say this is the person's blood pressure and their pulse and their past medical history and their medications. This was brief, to the point. It may include a minimum amount of information, and the commentator for this case said full set of vital signs is probably not necessary. I mean, you know what you got when they show up. As a little aside, when I was in residency, and I worked, when I first was exposed to EMS during my residency, it was in New Orleans, which at that time had the highest homicide rate in the nation. And we were typically seeing in the ER about 15 gunshot wounds a day. Those are the people that made it to the ER. When I was going around as a paramedic supervisor, I was declaring at least that many people dead on scene to save the hospitals the trouble of having to deal with it. And one of the things that was really great is the health department recognized that everybody was at risk because the shooters were everywhere. And we would go onto a scene and we would have no idea who was still active, carrying a gun, and whether they were still coming in to finish off the stuff that they had. So they issued everybody bulletproof vests, which was a little sobering to see. And after a couple of a physician and one of the senior paramedic supervisors were hit in the head, separate incidents, but bullets is coming out of the sky, because everybody liked to fire their automatic weapons in the air for some reason, and what they forget is the bullets that go up at the muzzle trajectory have terminal trajectories at the same level coming back down. So they issued Kevlar helmets too at that point, which is just crazy.
How close were these EMS providers to the hospital? Within like just minutes?
Yeah, they were close. They were. This was in Denver itself. Always consider paramedic scene safety. That's tantamount. Okay, next case. Let's see if I can get this to play from here. Okay, here we go.
Hey Doc, it's paramedic number 43 calling for high risk. Okay. I got a 17-year-old male that was skateboarding across an intersection and was hit by a small sedan traveling about 30 to 40 miles per hour. He rolled up onto the hood and smashed the windshield. There's a huge scar on the windshield. No loss of consciousness on scene. He was ambulatory on scene as well. He just got a dislocated right shoulder with some deformities. Got some abrasions to his right forearm and abrasions down his spine around the lumbar thoracic region as well. No tenderness or deformity is fine at all. Hemoglobin times 4. Last time I got blood pressure 112 over 68, a blood heart rate of 112. The upper right extremity is a little weaker on the pulse and not as equal as the left side. Blood pressure's at 18. He's 17 years old. I had his father come to the scene for a refusal. They're both still in top 10. Answer all questions appropriately. That's what I got for you.
So he has a dislocated shoulder. Why do they want to refuse?
Because they don't want their damn doing.
Do you mind if I just talk to Dad?
We sure can.
Thank you.
Okay.
Hi, how you doing, sir? This is Doug.
Good.
Hey, I'm actually really concerned about what happened today. So there is no such thing as a minor mechanism auto pedestrian accident. And your son has multiple injuries, and I would definitely prefer that he come in by ambulance, because I would hate for him to get sick on the way with you. Now, I completely understand your concerns with the cost and everything else, but your son already definitely has injuries that we've identified.
No, actually, I'll compare with which hospital will take him to.
So I think he needs to go to a hospital that's capable of evaluating and treating a trauma patient. And I think probably Denver Health or Swedish or one of the trauma centers should be the place to go. And I would actually prefer that they bring him on in here if you'd be okay with that.
Yeah, maybe Swedish.
And that's okay if that's your position as well. We can.
Be all another year still, so.
Sure. Well, sir, my concern is that I don't think, I'm absolutely concerned about your son right now, and I do not think that it's a good idea to refuse the ambulance trip.
Yeah. Well, okie.
So are you going to let them take him in?
I was talking to my wife before I got on the phone with you, so, I'll discuss the things with her, so.
So you understand my concerns, though, is that this could potentially, anytime there's a blunt injury like that, certainly at high speeds like that, he could have a lacerated or an injured kidney, injured liver or spleen, any of which of those things could kill him in a very short period of time if he had those. He also has an elevated heart rate right now, which is certainly concerning to me, and then he has a dislocated shoulder, which could be distracting him from all these other injuries.
Yeah, understood. Okie.
Well, I kind of need to know what we're going to do here, and I think that the paramedic should take him in.
Okay, no, take him to Swedish.
Okay. Thanks very much, sir. I appreciate it.
Yeah.
It's all right now?
Yeah.
All right.
I guess they don't want to come here, so,
I guess I'll let you convince them to go to Swedish, because I think it's a good idea.
yeah, so I think that's the right thing to do. So,
Yeah, make it. Okay, good help.
thank you.
Okay, bye.
It's a scary call.
GG basis.
Hey, Doc.
Okay, I think that's, okay. So,
That was a long-winded report. Good, thorough.
It was,
but
yeah.
Long-winded.
so obviously the kid's injured. He starred the windshield, he's been sideswiped, or head-ons, 35 miles an hour, left a bullseye in their windshields, dislocated his shoulder, his vital signs aren't really great. But a couple of things. The kid can't refuse himself. If the kid's alone on the scene and says, I don't want to go, legally, you can transport them. That's just something everybody should understand. The problem is if a legal guardian or responsible adult shows up and refuses transport, what do you do? And I think in this case, it was great that the doctor got the parent on the phone, because that's a recorded conversation, and this is such a high-risk scenario. There's a chance the kid could have gone home and been okay with a dislocated shoulder, but just as likely a chance that he would have died or had some other, something terrible. So one of the things that you should feel very, very comfortable doing is asking the online physician that you call to speak with the party that is concerned, if it's not already offered. Usually for these kind of cases, I think all of us are pretty quick to jump in and say, let me talk to the patient, or let me talk to the parent, because we want the liability to be clear, and it's going to be really on us anyway if the patient doesn't come in and something happens, and it's not your license, it's all of our licenses, because you're actually making the call to us. So you're getting some kind of protection by calling us in the first place, but even better if we can communicate directly. If multiple people communicate that and a patient or a parent still declines or refuses to go in, at least you've done what you can. In those cases, I would say there are some things to consider. You could think out of the box, because ultimately what you're trying to do is make sure the patient is okay. And it's not just, preventing yourself from being sued after the patient dies. So one of the things that, and it may be on this slide, but one of the things I considered is if the parent says, I don't want to pay for the ambulance ride, but I'm going to go to the hospital. The ambulance could follow the patient's car, so that if something happens, you just say, give us a signal. If he dies or passes out, honk your horn, stop, and we'll pick it up. But we're here to make sure that your son gets the care that he needs. And we understand that cost is always an issue, and you're worried about that. But let's just see if we can figure something out that still gets us to the same place, which is your kids taken care of. And we, it doesn't. It's not always as simple as that. There were a couple of times when I was working at St. Andrews after it stopped being an ER, when patients would have to go up to miles. And at one point, the cost of that ambulance transport was over $1,000, which is just ridiculous. And people figured that out. And there were a lot of people who had serious injuries or illnesses. One case I remember with a woman that had an IV in her and refused transport. And we worked out these elaborate systems, and I eventually let them all go by private vehicle. In one case, I think I had a police escort, and in another one, I just said, I'll take the hit for this one, because at the next staff meeting with the administration, they're like, you did what? We'll never back you for that. And I said, well, the patient made it to miles, and her care continued, and she got better. And that wouldn't have happened. She was going to rip her IV out and go home. And so my choice is to experience your wrath and tell you, have you tell me that I did a really bad thing, or think what's going to happen to this poor woman when she goes home in a diabetic coma without her IV because I didn't work something out for her. So these are always difficult ones, and I encourage you to think out of the box. One of the other things I want to say is we use the term refusal a lot, and it does have some connotations. When you think about somebody refusing, it usually is it has a negative implication. So in some cases it's right on, and they're really not communicating in any fashion that's gentle, it's antagonistic. But generally speaking, a kinder word to use that describes the scenario just as well as decline. Because there are a lot of reasons why people choose to do something. It's not always about them refusing to do what you recommend. They're declining it, and in some cases I put that down in my chart with a discussion about what the patient understood and why they said that they would do something else. And the reason I do that is because one of the things that we're tested on if a case ever comes to litigation is whether or not the person that you're trying to care for understands what you're saying in a way that is the same as a reasonable adult would understand. And if you use terms that are antagonistic, or you don't really fill it out, you just say the person refused and stormed out, and then 30 minutes later you find out that they rolled their car or they've been hit by a bus, and they were a psych patient and they were schizophrenic all along. We actually had a case like that in Miles several years ago. A woman who was a known schizophrenic came into the ER after stealing somebody's car. She brought her suitcase. She got to the door of the ER, and somebody talked to her. It wasn't me. It wasn't a nurse. but she decided at that point that she wouldn't actually come in for care, and she turned around and sped off and immediately got into an accident. And of course that all came back because I was the doctor on shift and was like, did you hear about this woman who, oh, and then when she was, being transported, she insisted on going to a certain place that was, it wasn't even really a place for trauma evaluation. She was obviously not competent to make decisions. So it's really important if you're actually having a conversation with somebody. In our case, it's when somebody decides to leave against medical advice, and you put down something to demonstrate that they actually could understand what you're saying, and they had reasons. They might not be reasons you agree with, but they're able to understand, synthesize the information, and come up with a reason. So like, well, tomorrow's my 90th birthday, and I wanted to, celebrate it in this fashion, and I'm going to miss my antibiotic dose tonight. I know that, but I'm willing to take the risk because I'm an old person, and I've lived a long time, and it's okay with me if I die. That seems to me to be a very reasonable thing, but it would be leaving against medical advice. And it wouldn't necessarily be refusing care, because it wasn't an antagonistic type of conversation that I had with that person. It's somebody who has a conversation with me, and they choose to do something else. I don't think there's anything else on here. Okay, so we're going to do another regular case. So you're called to go to the scene of an 8-year-old girl who's confused, vomiting, and lethargic. These are never like somebody with pharyngitis, and they're fine, right? She's been tired and unwell for 3 days with some mild abdominal pain and feeling feverish. Her initial exam on scene, heart rate of 120, blood pressure 95/60, respirations 34 and deep. She's satting fine on room air. She obeys commands. She's not completely there, but her eyes are open to pain. And she's dry. Kuzmal breathing. Do you remember what that is? That's very deep in and out breathing. It's usually breathing that serves the purpose of exhaling carbon dioxide as efficiently as possible.
Well, and depending on what her fever is why her respiratory rate that high to blow it off as well.
Could be, yeah.
It looks like it could be a metabolic issue.
Yeah, so that was my thought too. Any other thoughts about what this might be?
Ketoacidosis?
Could be ketoacidosis, definitely. So some form of metabolic derangement where she's got acidemia, or blood pH is acid, and Kuzmal breathing helps that because carbon dioxide mixes with water to form a weak acid. And if you exhale fast enough, the carbon dioxide that's gaseous in your blood leaves proportionally higher than when you are breathing normally. And the amount of carbon dioxide in your bloodstream drops, and the acid portion that's contributed to the blood by carbon dioxide drops. So we have something that's called a compensatory respiratory alkalosis. So what you're doing is you're de-acidifying the blood by over-breathing. And it's not the intake of breath which brings oxygen, it's the exhalation which blows. Every time you exhale, you're exhaling mostly carbon dioxide waste, and you can actually make yourself pass out if you breathe fast, because you change the acid-base balance in your bloodstream. That's the reason people do it and get lightheaded. It's because they're, we say, blowing off their CO2, which, if you look at a blood gas, turns into a different pH reading. And you can do it very, very quickly. She also has right lower quadrant tenderness with rebound and guarding. Yeah. But you can have, one of the reasons kids get diabetic ketoacidosis is because it's precipitated by some other illness, and appendicitis is a classic one. And she is febrile. Her temp is 38.5. So what do you do next? Fluids, absolutely.
Depending on how lethargic she is, if she'll handle BVM, just to maybe get her respiratory rate back down a little bit.
Maybe assist respirations. Anything else? Any other testing you want to do?
Oh, yeah,
That's
blood
available
sugar.
to you?
So
Good.
her
Blood sugar?
is-
Yep. So her blood sugar is high. So
Hence is
It
the breath
is,
on the
yeah,
odor,
exactly.
odor on the breath.
So this girl did have diabetic ketoacidosis, and I think ultimately also had appendicitis. So you give volume, and how much volume do you give, just as a rough
20
guide?
mLs per kg.
20 mils per kg. So she's, did I say she's 8 years old?
I think it's 9, but yeah.
8 or 9. So it's still going to be somewhere around 400 or 500 cc's of saline. Oh, I've got it right there. Look at that. The question is, with a high blood glucose, is insulin in the protocol? It's not.
Only
Okay.
if transfer.
Only in transfer. That's actually, well, you'll see what happens in this case. In this case, the kid got insulin, bolused. And that's kind of a gut reaction. We're all taught if the blood sugar is high, you bring it down. And it's unfortunately kind of a holdover from when you just see a bad number, and we're taught in some cases to treat the number rather than the patient. When you have kids with diabetic ketoacidosis, the changes in their volume status and the changes in what we call the osmolarity of their blood, so the concentration of their blood, if you look at somebody with ketoacidosis, which is marked by elevated levels of glucose in the blood, it becomes viscous. And if you change that quickly in an adult, it's usually not a big deal. They can tolerate it. But for some reason, worse things happen to kids if you do that. So one of the things that we've learned over 20 years is you can take, it used to be diabetic ketoacidosis, the first treatment was a huge bolus of IV insulin. And it usually was somewhere around 100 units, sometimes 200 units. And I have some colleagues, older physicians, who remember when they actually did that. You can rapidly reverse the glucose, but you're not fixing the underlying problem, which is this viscous blood and volume depletion, because they peed and vomited all of their liquid out. And that's the real problem. So volume is really, really important. In fact, now we teach our residents, you can forget about insulin in the first 4 or 5 hours. Somebody's going to die in front of you from diabetic ketoacidosis simply because they're in shock, because they're hypovolemic, not because their blood sugar is too high. So until you fix the hypovolemia and some of the other metabolic problems that go with that, no amount of number crunching for the blood glucose is really going to set you straight. We don't really have to go into how you dose the insulin. It's kind of a moot point. The other thing that happens in diabetic ketoacidosis is when you vomit or you pee out all of the liquid that's in your blood volume, you also lose some of the really important minerals that are in there. And one of the most important minerals we have, in addition to salt, is potassium. Your heart has to have potassium to pump properly. All your muscles have to have potassium. Potassium is one of the most important. It's the most important intracellular compound. Without potassium in our cells, we wouldn't be able to exist. So all that potassium gets peed out, and then you're replacing it with saline with no potassium. So what happens rapidly, well, what we usually see when you do a chemistry profile on somebody with diabetic ketoacidosis, you see that their potassium's high, and it's because they're so volume restricted and their blood's so concentrated that you're just seeing an artificial elevation of potassium in concentrated blood. But as soon as you make the blood normal viscosity by replenishing all the lost liquid part, you find that there's very little actual potassium in the bloodstream that's left, because you've diluted it back to normal. So if you don't add potassium back to these people in the ER when we're treating them, they usually have cardiac dysrhythmias and sometimes arrest. That's the biggest lesson we've learned about treating DKA in the last 20 years.
How long does it take a child of that age to recover from something? I know everybody's different, but what would have been a standard time frame?
Usually a day or two, yeah. Although you can make good headway in the first 6 hours, and you can tell because the kids just brighten up. So analgesics for this kind of patient are a little bit scary because you've got a kid that's already lethargic, who's obviously really sick, whose blood pressure is soft. Fentanyl still is an okay choice. If you've got a kid that's in a lot of pain, you can dose the fentanyl appropriately to weight, and because it's got a short half-life and you can reverse it, I have no problem with that. But the other thing that I would leave with you is nitrous is still around. And that's easy. It's self-administered. Kid takes a whiff. If she likes it, great. If the pain goes away, she's had her dose. If not, you can't overdose nitrous because it's self-administered, and once you get too woozy, you just can't operate it. And it's got, you know, a very good cardiovascular profile, and you don't have to have an IV. Okay, so after the first interventions, she was a little bit more confused. She's gotten the bolus. She's got a little insulin somehow. She's gotten some analgesics of some kind. She's complaining of a headache. So does that make anybody think of anything? This is a little bit of a...
I'd be curious just to see what her blood gas was.
Yeah,
I mean, we
it would
can't
be
do it,
interesting. Well, her glucose is better.
Right, everything looks
Yeah,
a little
everything
better.
looks a little bit better.
But is she
Yeah.
starting to decomp at
Yeah.
this point?
So I think the reason why this case came up is because this kid, as a result of the initial interventions, experienced cerebral edema. And that is something which we rarely see in adult patients. You can give 5 liters of fluid, lots of insulin, and get people perked up. We were even doing it in the urgent care for a while with that kid who used to come in and never want to be transferred, who eventually died. But the 8-year-old kid, even if you do everything right, the brain responds much more pliably in a kid that age. In fact, during neurosurgery, if you are looking at a brain in a young person, the anesthesiologist, by simply ventilating a little bit faster, you can see the brain swell out of the brain cavity or contract back in, because the carbon dioxide also has effects on the ability of the brain to hold fluid. It's a weird thing, but we always talk about hyperventilating people with head trauma, and that's really the theory behind it. Is when you hyperventilate, you can get the brain in certain people to shrink, and in kids you can really see it well. In the operating room, it's just the first time I saw that, I couldn't believe it. The guy says, "Watch this," and he does this, and the brain's like just disappears into the hole. It's like, well, that's a little creepy. I don't want to watch that again. Please don't do that to me again. But in the same way, any intervention, especially when you got these widespread metabolic derangements for diabetic ketoacidosis and probably fighting the infection from the appendicitis, we've given her volume, we've given her something to correct some of the chemicals in her blood that are overloaded, the glucose, and her brain swelled. And that first sign of brain swelling in a kid is when they complain of a headache. So there aren't really a lot of things you can do in the field about it, but there are a few things. You can decrease her IV volume. I don't think that's going to do a lot, but it will. You can add something that's hypertonic. And it used to be that we carry hypertonic saline around in all the rigs, and we even had it in the ER. We hardly ever used it. We still use mannitol every once in a while in the ER, It's very effective, but they're pretty much the same thing. And they don't give you a lot of time, but they might get you half an hour or maybe an hour if you're lucky. Elevate the head of the bed. It's my favorite one. We always write that in, head trauma or seizure patients. Elevate the head of the bed. Subarachnoid hemorrhages, and the idea is to reduce some of the compression because the brain's sitting right on top of the big hole that carries the spinal cord. I tell you the truth, I don't know how effective it is or not, but it's something to do, and it doesn't hurt the patient. Uh-oh. It just gets worse. So she vomits, she gags on her secretions. First thing to do, and the reason I put this in, is turn her on her side. Yeah. And I think all of you guys, I've seen you guys do this. It should be an instinct, but any amount of aspirated vomitus always becomes a problem. And that, that might have been what happened eventually off your 100-year-old lobster woman. But the stomach pH, the liquid in your stomach has a pH that's low enough to melt a nail. In fact, it used to be if kids swallowed nails, we would always send them to the OR to try to retrieve them. Now, I think the feeling is you leave them overnight, unless they have signs of perforation, you re-x-ray them in the morning, and many times the nails is gone.
Wow.
That's pretty amazing. Coca-Cola does the same thing, but over a lot longer period of time. So imagine getting that into your lungs. Aspiration pneumonitis, which is what we call it. It's not really a true pneumonia because usually the first thing that happens isn't an infection. It's just melting of the lung tissue by the acid that comes up in the stomach. And usually the people that experience it are sick to begin with. So you're taking somebody who's sick like this kid and you're basically squirting a lot of acid into their lung and saying, take that and see how you like it. So everything that we do when somebody vomits is to prevent the first inhalation of that first stuff that's coming up. So you flip them over on the side, try to turn their head down. Sometimes I whack them on the back a little bit, get a suction catheter or something up in there so everything comes out instead of going in. We talked about intubation on one of the other cases. This one's about the same thing. The other case was anaphylaxis. The kid was already desatting. This is a person who needs to breathe fast, who can't afford to be down for very long either. And there are some things that we can do that counteract the acidosis while we're intubating to try to keep them from radiating down or arresting. Bicarbonate is in there, and it's something we rarely use bicarbonate anymore, but this is one of the times when we would. Uh-oh. Just doesn't get better. So she's intubated now, and she rests. And you start CPR, do the epinephrine, consider bicarbonate. I don't know why I put this in. Confirm tube placement. Because we know she needed the deep breathing. When you were talking about controlling the rate of breathing, in this kind of case, on a ventilator setting or somebody manually bagging, I would tell them to bag deeper. Yeah, you want to increase the amount of gas exchange so that a lot of the bad stuff that's coming out of her bloodstream can escape through the lungs. That's basically the idea, but it's carbon dioxide.
How much damage does the stomach acid actually do to the small airways when you get into the alveoli? And does it actually burn them at that point?
It does. They're early on. So I trained in a place that didn't believe in RSI. So we gagged a lot of people when we intubated them because we'd intubate people when they were awake. You just hold them down, and everybody threw up. And we had all of these cases of aspiration pneumonitis. And so we all got pretty good at, knowing what the statistics are. But it was something, I remember the last time I read it, something like a 40% mortality rate for significant aspiration from pneumonitis. Those numbers are better now, but part of that's because we have better methods for intubation. And most everybody that gets intubated, electively gets pre-dosed with an antacid. They're on an empty stomach. There are a lot of other things that anesthesiologists do. If we're intubating somebody that we know is at high risk, sometimes we'll have an NG tube ready or have suction right there and empty their stomach beforehand. There have been times when I've intubated people sitting up because I knew if they threw up, it would be easier to control it, but it wasn't worth the, just, it was a good idea, but it didn't really work. So, to answer your question, it can be really, really bad. We see probably a lot less than 40% mortality now, but it can be as high as that. Okay, so let's go back to the audio ones.
Hey. Hi, Doctor. This is Ambulance 11. Can you hear me okay?
Yeah, go ahead.
I have a 7-year-old male, had a witness seizure. He was given 10 milligrams of rectal Valium. He started to clear a little bit, and then he had a second seizure. I'd like to go ahead and give him 4 milligrams of IM Versed. His last pressure was 92/70. He's got a heart rate of 130 and breathing at 30 times a minute.
So you said he got Valium in the clinic, though? Would you guys be able to continue with Valium?
Unfortunately, we don't carry Valium on our ambulance anymore, so per our protocol, we'd like to go with the Versed.
Okay, so you said you'd like to get 4 milligrams of IM Versed?
Correct.
Okay, that sounds reasonable.
All right, thank you.
All right, thank you.
Bye.
Bye.
So this is a pretty straightforward case. Kid with a seizure. The medic is calling in for permission to give something that's actually on the protocol, and I don't know the legality of that in their system. I know in this system you could just give the Versed, right? You know, you have to get online medical control to give Versed for protocol.
You gotta wonder,
Depends.
protocol
Depends.
says we can give it, but if they've already been given the Dilantin or
Right. The Valium.
the Valium, you may want to call and just, I would probably call and say they already got 10,
Yeah.
so
What's safe?
what do you say?
Yeah.
You know,
No, and I'm fine with that. I always like getting your calls, and I want you to feel like we're a resource rather than a gateway. But one of the things that I included this for is this particular practitioner wasn't that familiar with the EMS protocols, so she didn't know that Valium was no longer carried on the rigs, and she may not even have known that Versed was indicated for pediatric seizures. So the call served the purpose of also just not just getting the permission and finding out if it's okay to give it on top of a dose of Valium, but helping to educate this med control person that this is something that you can do, and getting her permission to do it. The other issue that I think I wanted to mention is because she didn't know about this, in this particular case, and I don't think I wrote this down, but I was reading further in the case, she mistook the order for IN, not IM. And and listening to it again, he clearly said IM twice. But when she recorded the call, she thought it was going to be delivered intranasally. So it's very important to get not just the name of the medicine and the dose, but to confirm the route if there's any, and I never would have even imagined that was going to be, if I thought there was a confusion between IM and IN, I would probably guess IM, because IN is just a little bit further out there, but maybe not in this system. So it's a fairly simple case, but it just drives home the point. We're not all going to know what your protocols are. So if you get into a situation where you've got some options on your protocol, and the physician's pushing back and saying, well, why don't you try giving the vitamin C injection, just calm down and say, well, our protocol actually only allows us to do these 3 things, and which of those things do you think is the best? And that's helpful to us. one of the things that I sometimes hear, there's a technique in psychotherapy and also in military communications, and now in emergency medicine, patient handoffs during shift change to get us to clearly paraphrase but mirror back what the other person is saying in at least the most important elements of that. So in this case, if I had been a responsible physician, I would have said, okay, I hear you say midazolam Versed, 4 milligrams, IM, meaning intranasal, right? And I think that would have been picked up right there. It's a small point, but it's something that I practice, or try to practice. I'm not still the perfect communicator, but it's a good technique.
Yeah, that's 28. Can you hear me okay? Yes, go ahead. I take it you've gotten word already on our little FCI that we have going on? Yes. Okay. What I have right now currently is a total of about 14 to 17 spinal immobilized patients. All stable, all appear to be walking wounded with the exception of complaints that would categorize as spinal immobilization. The majority of them are minors. What we need to know is how many patients we can send to which hospital. Can you take care of that for me?
We will get that on. I will. Do you mean I'll dispatch with the with what we decide?
Exactly. That would be great. Just
14 to 17 spinal mobilized patients.
Yeah,
Okay.
we are on the east side of town, so just kind of start working your way, I guess, across the city that way, and we'll figure out what we're going to do.
Okay, thanks. We'll do that. Okay.
So this is an interesting case because it's a logistical nightmare. You've got, if these were adults, they could all refuse care. They could, you could triage them. But you got, what, at least over a dozen kids. They, in this case, there was no responsible adult on scene. I think the bus driver was injured or gone or whatever. But and wasn't the legal guardian for all the kids anyway. So you got all these kids. You can't clear them on the scene. There's no responsible adult, and they can't refuse transport. So what do you do?
Now, would there be a way to call like the parents or get in contact with the school to see if they can call the parents to, like, if we can move the patients if they're not injured to the school?
Yeah.
And at least start with that way, and we can minimize the impact on the hospital.
That is a great idea, and that's the reason I included this call, because it's another one of those where you got to think a little bit out of the box. This isn't time sensitive. These people aren't critical like that first MCI where there were critical kids on gang shootings. These are just kids that need either to, if they're not injured, to get their care assumed by somebody who can vouch for them, either a parent or maybe a school administrator. But in order to transport the kids that need to go, you've got to somehow clear the scene. So you ask for help. And
because I
that's
know,
a good
I know
idea.
most of the cases around here, if we get a bus accident, the other bus is already on its way. So
Yeah.
if we could transport the kids over the bus, send a provider on the bus with them, so if something should happen,
Yep.
and then have the rescue follow to the school and then start triage from there.
Yes.
That way we don't overwhelm Miles, Penn Bay, and all of that.
Well, I think ultimately the state of Maine says if something mass casualty happens, some of the rules change. They make some exceptions as far as who can act as a guardian for that child in the event where a bus or something big like that happens. I think
Right.
the school principal, can make some of those decisions based on acuity of injury and whatnot, and then they can legit to move them somewhere else.
We've actually done that here. We had a bus get rear-ended on Manktown Road a bunch of years ago. And so now what do? This is back when we boarded and collared everybody, and nobody was hurt. It was
Right.
a small car that rear-ended the bus, but now
Two
you got,
injuries, but they were minor.
yeah. And
Yeah.
so what do? We call medical controls. If this is what we got,
Yeah.
this is, I don't want them. If you don't think they're injured, deal with them. And I think what we did is have the school bus driver
Yeah.
sign off on the officer, and we wrote it up as, we didn't take every name, date of birth, and write a report for every student.
Yeah.
So, but again, I think that goes with what Derek said, the mass casualty thing. You've got rules that it's not abandonment if you leave one to go school to another, and because
That was
of that.
kinda like the one Richard and I had down in town, I don't know, last year, 2 years ago. And it was a minivan with a bunch of children that were to another mom, not the one that was driving. And I had to wait for that mother to come
Yeah.
on scene and just
I
say,
remember that.
hey, can you actually
Right.
sign these guys off? Cause,
We've done phone calls too.
Yep.
And
Yeah.
verified with parents, hey, I have your, you know, they're not complaining of anything, is it, you know, you want them transported, and 9 times out of 10, they said leave them with the bus driver.
Yeah.
Didn't we have issues too, the van accident by the state park in Jefferson, that the permission forms to treat, there was all the state children.
this wasn't the,
The permission forms though were just for at the camp site itself and not off-site on public highway. There was some real convoluted thing.
Must
But
have involved lawyers.
it got worked out though. I think the camp insurance paid for all those transports, but those kids, they weren't injured. They were just,
Yeah, but everybody had complained. We transported.
Yeah, everybody had a
from that.
complaint,
We-
yeah.
I think we transported 6 people from that bus.
Yeah.
And everybody had complaints. It was-
we had Delta and Union here, all 3 of our trucks.
Wow.
It's kind of like where we had the van was transported to
Special
mentally
needs
challenged.
Yeah.
Van, one of the vans, I think there were 6 residents and driver,
Yeah, and they all went to miles.
and they were hit with another car. The driver of the other car was taken to Penn Bay. The other passenger in the car was uninjured but was an adult. The driver of the van said, it's our policy that if there's any accident, that all clients go to the hospital.
Oh, gosh.
Six of them.
That was the hard part too, because we had.
We were pulling 2 out of Waldeboro, Thomaston.
We took,
Warren.
one extra
Northeast
truck
took-
from Friendship.
Northeast too, yeah.
And
We took a
Northeast.
truck from Friendship down, and we took one patient, it was difficult because we got called late in the scene of it. And we got to Miles, and on our way to Miles, we couldn't put a collar on this patient, wouldn't tolerate it at all. And we got a little pushback from the hospital at first about it, but we tried explaining to him, this is an MR patient. He's
Yeah.
refusing everything, I can't force this on him because he's willing to jump out of the back of this ambulance.
Yeah.
So, I mean, as it was, we had to bargain with the guy with stickers to get off our ambulance stretcher onto the hospital. So,
I think one of the patients developed his own symptoms on the way in.
Yeah.
Kind of made him up as
One
he went
thing
along.
we do try to do, Doc, is we try to split them up, if we can. You know,
Yeah.
if we have a 2-car pileup right here on Route 1, you know, we don't like to separate husbands and wives or, you know, mothers and sons, but
Yeah.
if we can, you know, if we can take 2 to Penn Bay and take 2
Yeah.
to
One
Miles,
vehicle.
do our
one
best
day,
to do
one
that.
vehicle.
That way we're not, you know, rolling up on Miles and with 4 patients right at once, so, you know, things like that kind of.
So there are a lot of great solutions to these, as long as you're willing to work them and not be rigid. I also heard of, actually, one case when I was working, different ER, EMS was overwhelmed. It was another bus accident. I think there were 35 kids on board. And and nobody was seriously injured, but the bus was still drivable. So a medic got into the bus driver was uninjured. They drove the entire bus to the ER.
Let's do it.
And we all just came out and triaged the kids, you know, as they came off. And then at least they were in one place, so when all the parents and school administrators got there, they knew where the kids would be. Let's see if, I don't think there are really any other, I want to get to what they did. Oh, here we go. In this case, the police contacted the dean of the school. The school sent a responsible adult to the scene and assumed care of all the children who were uninjured. So they did something similar too, so you wouldn't have to transport them all. Okay.
Go ahead. Hi, this is Paramedic. Calling you for 10 setup for the deck. Can you hear me okay? 10 setup for the deck.
So that's the terminology for critical resuscitation.
Okay, I will get pulled above okay for you. Right now, it's a 3-year-old auto says she's a respiratory arrest. She's got a heart rate of 80. She's completely unresponsive with some pretty decent head trauma with about a 3 to 4 inch laceration to the top of her head. She's also got a lot of illnesses to the mouth. We're suctioning her and assisting ventilations with a BDM and an OPA. I will pull out my barbell right now.
Okay, I'm gonna wait for that. How far out are you?
We're about 5 to 6 minutes. We kind of just grabbed her and went, so we've got her in a KED, and that's about what we've got so far.
Okay.
Put that at her head, please. Okay. You'll put her in, we'll say she's right on the end of yellow and white. We'll say white.
White, Bravo
Yes,
white, okay.
Yes.
We will see. Bye.
Okay, thanks, bye.
So the purpose of this call is just to, so there's obviously a critical patient undergoing resuscitation on scene. The reason for this call, again, and for any of these communications, is to facilitate the best care for the patient. And I think this medic did a very good job. She needed the ER to be ready for them. And the doctor, on the other end, I think also did a good job in not asking for a lot of extraneous information. The most important piece of information is what equipment do we need, and that's the Broslow. So those two things were communicated very, very well, and that's really, if you've got a high stress, critical patient, and the doctor is keeping you on the line saying, well, you know, what's his med list? Can you show me what his med list is? Or, you know, stuff that just make it clear, look, we don't have time for this. I'm letting you know we need to go to room 1 and set up this equipment. And that's totally appropriate. Let's see if there's anything. Pertinent vital signs, if you think they're going to affect care, intervention's already underway. Oh, an ETA. We like to know. She did. She did. Okay.
TV base. Hi, Dr. 127. Can you hear me okay? I can. Okay, calling in for a field pronouncement for a pediatric patient. This patient is almost 1 year old, birthday in September, was last seen about 16:30. The older kid, I guess, was filling up the bathtub. Mom stepped away for about 15-20 minutes. Came back, baby was in the bathtub, face down, and was lifeless, pulses, apneic, water was coming out of her mouth. We've been working her since about 1700. She's still for almost 20 minutes now. We've done 3 rounds of CPR. She's been asystolically the entire time doing us working her. No changes, no meds, no history, no allergies. Anything else you want to do? You guys, I know you guys don't usually do, but kids, right? Yeah, we normally don't innovate. Okay. Are you one of those? I mean, you can try to innovate if you'd like. But said 1 year old. Yeah, she'll be 1 in September. Okay. And how warm was the water? The water, we're not exactly sure. She's filling up a bath. I assume it's warm, but she's cool with touch. It's pretty warm in here as well too. And she hasn't made any changes since you've been with her. Okay. And so pulseless, apneic, and you guys have been trying to bag with any resistance? No resistance with bagging. I'm having okay in place. No problems on our end with that. Okay. All right. Okay. Guess we will call time of death 1918. 1818. Okay. And tell you last name again. 18. Actually, give me just 1 second, okay? Okay. Can you give me 1 second? I'm sorry about that. I just talked to a senior attending, and we're kind of having trouble with calling it, and we'd like to bring her in and at least get a definitive airway in. So if you could sit for the lady. And are you coming to the desk? Yeah, we'll be going to the desk. We should be there in about 15 to 20. Okay, appreciate it. Okay, thank you. Okay, bye.
Yeah, this is a tough one. This is a tough call. So this is it wasn't the greatest audio. An infant, 1 year old, found drowned in the bathtub, obviously dead, obviously been worked for a while, and the medics are calling for a field pronouncement, which I think is totally appropriate. This, I think, has probably a resident early in training who is a little bit unsure of what to do, and is asking questions that are a little inappropriate, like what temperature was the water? I don't think there's, I think she probably was thinking,
Cold.
oh, I've heard cold water drowning is an issue. but it's not relevant really to this case. So she eventually comes around to being willing to call it, pronouncing, adding time of death, but there's probably an attending standing right next to her who's not quite sure. So you're kind of, you're going back and forth. And I put this in because it's a real life case and this kind of stuff happens.
Doc, was that the attending that said to bring him in? Or was that the senior medic on the scene that decided to transport?
That was the attending in the hospital.
Okay.
Yeah, the medics wanted to call it at the scene, which I think would have been appropriate, and that would have been an okay call too. So I put some of that in here. The most important things that were conveyed in the call, the medic did a great job, were the injuries, the incompatibility with life, obvious signs of death, duration and effectiveness of their CPR and resuscitation. Just as a reminder, what you need to get a field pronouncement includes the signs of death, things that are obviously incompatible with life, and we're all familiar with that whole morbid list. Or fetal medical resuscitation is defined by your local protocols. They threw that in. I don't think there's really anything big that falls in that category. A DNR, which I think is what was in your case. And just remember, if a pronouncement is made on scene, this applies more to urban jurisdictions than to ours, but in a lot of jurisdictions I work, you've got to leave everything in place because there is a likelihood that it could be a coroner's case. There are so few coroner's cases in this part of Maine now, and I think it's because we have a hard time finding coroners, and there's really not that much in the way of state resources to do autopsies. So even when I have had obvious coroner's cases in the ER and I've called, sometimes I've had to really work on the state to accept a case. That's barring the cases of obvious criminality, or there are certain things that always make the cut. But
well, that age, children are automatically
yes,
in the, so that age would automatically
it would, because of the possibility of abuse. So in this case, it would be important if you did have lines and things like that to make sure that the parents knew, you got to leave them in place, because that's going to be part of the information that we need to gather to figure out what actually happened to your kid.
That also happens on the prison, because every death in prison is investigated.
Oh, I didn't know that. Okay.
We had 2 in the last week, so.
That's
I
right.
actually took them on Saturday from the funeral home to the medical examiner's office in Augusta, and everything had to be left in place.
Interesting.
Yeah, we unhooked the machines, leave everything else.
They had magazines and everything.
Wow.
They even took everything we took off in a bio bag to save that.
Okay, good. Good.
And neither one of these was suspicious either.
Yeah, it's
They were
interesting
both
what
medical.
they focus on. It is. Then the last thing I've got here is the decision to transport. In this case, I think it was because of uncertainty on the part of the attending and some communications that just wasn't ideal. But you've all been in cases where the scene's very, very difficult to control. There's a lot of chaos going on. Somebody's obviously dead. People are wailing and screaming and beating on the hood of the ambulance. And I've been involved in cases like that too, where you just take the person, the dead body, in the back of the ambulance, and you leave the scene. So it's for scene safety and your safety. There's one case I remember being involved with, obvious cardiac arrest, lividity. The guy had been down for a long time, but it was in the projects, and there literally were 500 at night, and there were literally 500 people blocking the way of the ambulance as we came down the stairs with this guy, and screaming and yelling and then firing their guns in the air. So we got out of there. I just said, grab his wife, put her in the front, and we're going to drive. And we didn't have a receiving hospital. And I knew the guy was dead. I actually pronounced him. So, and I was, so I called, the first hospital on the list, and they said, well, if you declared him, we don't need to see him. Don't bring him here. And I'm like, huh? So I called the second hospital on the list. It was a rotating deal. They did the same thing. No, we don't want him. We don't want him. He's dead, huh? Okay, nope. Don't come here. I don't want to fill out the paperwork.
The next call was he's a PEA, right?
It should have been. We drove around for 45 minutes, and we're in downtown. There's hospitals everywhere. And finally, I called the hospital that I worked at, and I said, I'm not on shift, but I'll do all the paperwork. I just need like an empty room in the back. The hospital where the guy actually was a patient wouldn't even take him. But after 45 minutes, because his wife was still in the front seat, and she had no idea what was going on because it was an ambulance that had a barricade, so there wasn't a way of communicating. So I just told him to drive up, and I'm not going to offload the patient, but I want to take the woman in and tell her what happened. And they wouldn't let me pass the waiting room. The doctors came out and said, we told you on the radio, you can't come here. And I'm like, I just need to tell his wife that he's dead. And it's like, well, do it out there. I mean, this was like nasty. So at that point, I just like, I'm sorry, ma'am. I want you to know what's going on, but I found a place. We're going to go, and then you'll have some time to be with him while I work on the papers. It was crazy. But things like that happen. And if you need to get out of a scene for safety or for some social reason, it's okay. In fact, it's something that happens, I think, more often than we think it does. The last thing here I think is important. We see a lot of bad things in our business. Kids who are really severely sick or injured or have an emotional impact. An infant who drowns in a bathtub, a SIDS case. Generally speaking, if we have the resources to debrief, I think it's a really good idea. And so if you guys have cases that come up that are really disturbing and you want to talk about them and you don't have a formal way of doing that, that's one of the roles that I play. And I'm happy to talk to you about them individually or as a group. Okay, how are we doing on time? Am I putting you all to sleep? Okay, because I've got a couple of other woozies.
Everybody good?
Okay. Pick it up.
43, can you hear me okay?
Go ahead.
Calling to document an AMA refusal LP event for a 18-month-old male. Sounds like the little boy was kind of throwing a temper tantrum in the front entryway of their home, kind of threw himself backwards where he hit his head on tile. They described about a 30-second LOC and kind of apnea event where the child kind of turned blue in and around the mouth. Grandma grabbed some water, threw water on him. He immediately woke up and started crying at that point.
Okay.
Upon my evaluation of him, he is awake and alert, acting appropriately, interacting with mom and us. I do not see any trauma on him. I can't even see an abrasion where he would have hit his head or anything like that. Pupils are equal round reactive. He's got an apical heart rate of 126 and a respiratory rate of 32 with clear breath sounds. No significant medical history. I've given mom risks and precautions for closed head injury, as well as seizures, and she would like to transport him POV to the hospital. Which hospital is there? Yep.
Okay. Is that far from her?
No.
Okay.
No. Yeah, it's maybe about 3 miles, 4 miles from here.
Okay.
Okay?
That seems fine. As long as, I prefer them to be evaluated, but as long as they're thinking of going into POV, that's okay.
All right.
Okay, thank you. All right, bye.
So, were you able to hear that audio? ALTI is the term that he used, ALTI event, apparent life-threatening event is Is that something that you've ever heard before? It comes up in pediatrics now. So this is similar to the case that we had earlier about that one was a high-risk refusal. Remember, that was a kid that got slammed by the car, dislocated shoulder. This is a younger kid who looks fine, had a very short duration of something. It's another call just to get the doctor's idea and okay for the next plan, which basically was decline of EMS transport, but we've got a good reason for it. And a couple of things that I would say, I didn't know that, but if you transport a child against the will of a competent legal guardian, and safety is not a concern, in some jurisdictions that's considered kidnapping, which is a pretty serious charge. I didn't realize that. So that's, I guess, what happens when the lawyers get involved. The real life answer is to communicate well and gently with the person and impress upon them that your primary concern is that the patient gets cared for and does well. Do all pediatric calls need a refusals acceptance? That question came up, and I don't know the answer to that in Waldeboro. Does anybody? So, I think the question is, if you go to a pediatric call and mom says, I'm not going to take her in, do you have to call medical control and get that okay? You can actually sign off on your own.
You can,
Maybe
but
EMS says you can.
Yeah.
Just sign them off, but.
it's just safer to cover everybody's backside and
Yeah.
make that call.
Okay, so the answer in Maine at least is no, but especially for high-risk calls, yeah, always.
There's a lot of
get it.
people who still, even codes.
Yeah.
We don't have to call to terminate a code, we can do that.
Okay.
But a lot of people who especially been doing it for a long time are doing it the way they always have and call the doctor, say, is it okay if I stop CPR? And we don't have to, but it doesn't hurt. You've got a doctor,
Was it 2 years ago, Mike, they came out with all that big mandated reporter stuff? We had to do classes.
The mandated reporting.
So what's different than online medical control, obviously, but if it, if it's suspected abuse or, whatever, we technically, like, if we think safety's an issue, obviously take them out of there, but we don't have to get a medical control call then either, but you have to call the state and say.
I see, you think that there might be some issue here. Got it. Okay, this is good though. Whenever you have a refusal, actually we've got such a good system with the computerized chart reporting. I don't think this is an issue for us at all. But they're, they are saying you got to get the relationships of the patient, the person who's declining, chief complaint, location, whether or not the risk is acceptable, full set of vital signs, and return precautions. I think we already do pretty much all of that automatically if there's a refusal in the chart that comes up that's automated, right?
I think the only time I have it on a PED is basically when you can look and you can see the PED is fine and mom says just don't bother, I'll sign.
Yeah, that's fine. Okay, these are two quick final audio vignettes, and really the point here is you can't quite understand what the age of the patient is. And then I've got one more follow-up.
Yeah. Hi, this is number 23. Can you hear me okay? Yeah. She's 23, right? So that's a 4-year-old male. With history of seizures, it takes a episode for it. It's been one way he has a seizure, it takes about 10 minutes to come out of it. At 15 minutes, they call the PA unresponsive with the ECS segment, 1 to 1 to 5. Blood pressure was 106 over 50, heart rate 76, respiration is 30, right pupil is 6 at 5 millimeters, left pupil is responsive at 3 millimeters. Trying to get an IV for you, and we'll be there in about 7 minutes. What's in video? 152. 152, and how long has he had the seizure? we probably on scene, you got 20 minutes ago now? Okay. It's 20 minutes. Okay, and how long did you get here? About 7. 7. Okay, we'll see you then. Thank you, bye.
So the audio on that call was horrible.
I think I got 4-year-old out of it.
Yeah, it was either 4 or 40, which is what I wrote down. And it would be really, really important to know the difference because a 4-year-old with a blown pupil and a seizure is a really, really big deal. A 40-year-old who's had 25 seizures, who's got a pupillary defect, and maybe is on, seizure meds is a different thing altogether. Okay, so let's see if I can do the next one.
Your point drag 100 is 110 over 62 pumps is 100. You're chatting at 100%. This should be there in about 5 to 7 minutes. Any questions? Thanks.
I didn't even hear the age. Let's see if I can start that one over.
Number 22, paramedic. Can you hear me? We're brought to your facility looking for a 10 setup for a 60-year-old male who was hit by a car, unknown rate of speed, although it sounds like witnesses reported he was dragged underneath the car for about 10 to 15 feet. He does have some deformities to his head, but no bleeding. He's conscious and alert for us. Blood pressure is 110 over 62, pulse is 100. He's chatting at 100%. This should be there in about 5 to 7 minutes. Any questions? Thanks.
That always gets me 50 or 15.
I think I heard 50
Always
out of
gets
it.
me.
but-
Yeah, I think I heard 50 too, but the vital signs were more consistent with a 15-year-old.
Correct.
Not a 50-year-old, 105 over whatever. So it's an obvious point. And one of the teaching points here that these people suggest is that we provide 2 confirmations for age. It's the first time I've actually heard that. It makes a lot of sense.
A lot of times on the radio, I'll do a 63-year-old 6'3",
Yeah,
just
Yeah.
to verify, because 15 and 50 they don't get.
right. Or 4 and 40, or they're static. They go on to suggest including things that if it's a pediatric case that are pretty obvious, like in addition to the age, it's a pediatric patient, or her weight's 10 kilograms. The color is purple on the brows length tape. I guess that could be some little old ladies. We're transporting to the Children's Hospital. Okay. So that's a nice little teaching point. Okay, this is the final one, and it's sort of pediatric. So you got a 17-year-old girl complaining of abdominal pain for an hour. Here's her initial exam. Heart rate of 120, blood pressure is normal, respirations are normal, oxygen saturation is normal. Obviously in pain, she's cramping like her period, but much worse. Abdomen appears full turn.
Oh, good.
Yeah. Uh-oh, gush of clear fluid.
Wow, this happened.
No blood. Yeah. What?
They make TV shows about that.
The patient then screams, "I feel something down there." Okay, so this is the real reason I put this in. Yeah, we've got a breech presentation. So what do you do next?
Drive fast.
Yeah. One of the last OB calls I was involved with, it was late night at Miles, and the labor and delivery nurse calls and says, the obstetrician, we can't get a hold of him. We've been trying for an hour, and the woman's pushing, and I see a leg.
Stop pushing.
Yeah. So can you please come up here, Dr. Lee? And I'm like, a leg? It's supposed to be the other way around, right? Head? Just to remind you. She says, yeah, it's breech. And I'm like, great. So I go up there, and the woman's just like, can I push? Can I push? And I'm like, no. Can we cross your legs? And I'm just trying to reach back, because I've done a lot of OB, I've done a lot of regular childbirths, I've even done cesarean sections for breech, but I've never delivered a breech. I've watched it done many times, and it's one of those high-risk things, because if you remember, the head is the largest part of the body, and if the head doesn't fit through the pelvis, you've got to do a C-section. So
Or you break the
every, or break the pelvis, right? Every breech in the United States, it's known beforehand, is a scheduled C-section now. Very, very few are born naturally. And the simple reason is you can deliver everything else, but if the head gets stuck there, the kid's dead. And then what do you do? So I'm trying to reach back and think, well, what are the techniques that I remember learning? Because you all learn these techniques for breech deliveries, but because there's so few, it's like that other issue we're talking about. You've got to have experience in real cases. It's frequently done enough that you maintain skills, and I just didn't have the skills. So fortunately for me, Mike Clark walks in, and he's the pediatric guy on call, and I'm like, well, you're also a family doctor. How many breaches have you done? He looks at me, he's like, I don't want to be here, and he backs out of the room. And then he pokes his head in and says, I'm being called here for the pediatric portion, as long as that's clear with you. And it's like, well, we could tag team it. So we're both standing there like, back against the wall, and the woman's like, well, what do we do? And I'm like, well, to the nurse, you can put an IV in her. Just get her to do something. And the nurse says, well, we usually don't put IVs in our normal births. And I'm like, in this case, I think it might be worth it because there could be a complication. She says, oh, good idea. So she gets to work doing the IV, and at the last minute, so I get gowned up, I'm draped, I've got gloves on, the legs are sticking out, and I'm just thinking, okay, I guess we're going to have to do this and just like wing it, because I don't remember anything about delivering breeches. I don't even remember any of the techniques. I don't even remember which way the baby's supposed to point. Yeah, but we'll just do it. And in walks the obstetrician. And it was the most terrifying delivery I think I've ever seen, because the obstetrician didn't use any technique. The head got stuck, and she just grabbed the kid's feet, basically put her foot on the bed and pulled, and the kid's neck is like, ah! And eventually it popped out. But both Mike and I are like, we're out of here, because that kid's there's got to be some spinal injury or whatever. And so I'm really happy to be able to review the techniques, because that's not how you should deliver breech. The obstetrician just, I think, was winging it too, and just was more confident than we were, and I'm glad that she was the one that delivered it. So I brought a video. It's by the World Health Organization, and it's on breech delivery, techniques. I can't figure out how to do it. Yeah, we might have to shut off the light to... And I can review some of these. So this is a simple spontaneous breech, face down, so the buttocks are anterior to the patient.
As long as the delivery progresses spontaneously, resist the temptation to pull the baby down, up to the point that the shoulders have delivered. Once the baby's head is engaged in the pelvis and the hairline is visible, control the delivery of the head with a method such as the Morisot-Smellie-Veit method. With the baby straddling your right forearm, position the third finger in the baby's mouth and the second and fourth fingers on the malar bones. Place the second and fourth fingers of the left hand over the shoulders and the third finger against the occiput to maintain flexion while the head is carefully delivered.
Okay, that's probably the most important thing that I'd forgotten. So you're cradling the baby's head with both your hands, and the hand that's underneath, your middle finger gets stuck in the kid's mouth, so you get leverage, and your two other fingers on each side, so it's your ring finger and your index finger. She said the malar bones, that's the cheekbones. So you've got one finger in the mouth, and the other two fingers just lay on the baby's face. So you've got the baby's face planted in one hand, and you control the baby's head, the back of the head, with your other hand, and that way you can guide the head out of the pelvic canal with some control. And that is the most important technique for
It's more complicated. The extension of one of the baby's legs is an unfavorable factor. In the case of a frank breech presentation, splinting of the baby's body by both legs may prevent progress. In such a case, deliver the legs by gently flexing at the knees. When the umbilical cord appears, pull down a small loop to prevent traction on the cord later in the delivery. The baby's back will usually rotate anteriorly. If it is tending to rotate posteriorly, hold the baby with a towel around the pelvis, not shown here, and gently turn the baby so that the back faces anteriorly.
The back faces the patient.
If the shoulders do not deliver spontaneously, despite effective bearing down efforts, their delivery may be assisted by various maneuvers. The anterior arm may be delivered by passing 2 fingers over the baby's back, along the humerus to the elbow, and sweeping the arm around in front of the baby's face and chest. One or both of the shoulders may be delivered by the love set maneuver. Hold the baby by the pelvis with a towel, not shown here. Rotate the baby through 180 degrees back uppermost, so that the posterior shoulder appears below the symphysis pubis to be swept down over the baby's face and chest. If the baby cannot be rotated, the posterior shoulder may be delivered by lifting the baby upward, chest towards the mother's thigh, passing 2 fingers up the baby's back, and sweeping the posterior arm over the baby's face and chest. Once the arms have delivered, encourage the mother to bear down until the baby's neck and hairline appear, indicating that the head is engaged in the pelvis. If the head does not engage, the Morisot-Smellie-Veit method may be used to push the head up slightly, rotate to the oblique diameter, flex it and pull down. Suprapubic pressure may be used to assist flexion and descent of the head. Here the baby's head is delivered by the Morisot-Smellie-Veit method, as described before. An assistant may support the perineum. The second breech delivery shown, though difficult, took 4 minutes, and the baby was in excellent condition after birth. An alternative method of delivering the head is the Burns-Marshall method. Once the head is engaged and the hairline is visible, hold the baby by the ankles with your left hand and swing the baby through an arc up to a vertical position and then over the mother's abdomen. Support the perineum with your right hand as the face delivers. Infiltrate the skin and subcutaneous tissues overlying the symphysis pubis with local anesthetic. 2 assistants support the mother's legs.
This isn't a
to prevent
technique that you'll be doing in the field, but basically you use a scalpel and you cut through the symphysis pubis, the fibers, to let the pelvis open, just maybe a quarter of an inch, or sometimes that opening gives you
move the urethra away from the midline.
room to deliver a head
Make a
that's
small
stuck.
vertical scalpel incision above the lower part of the symphysis pubis. Angle the blade toward the top of the symphysis pubis. Cut the anterior fibers of the symphysis pubis with a sawing action from the top to the bottom of the joint, keeping a thin layer of the innermost fibers intact. Deliver the head by the Morisot-Smellie-Veit maneuver, or with forceps. The symphysis pubis separates just enough to allow passage of the baby's head. It is useful to routinely have a local anesthetic, a scalpel, and a urinary catheter available during breech delivery in case an emergency symphysiotomy is needed.
Back on.
Hey Richard, you can drive that day.
So really, this is probably not something you'll encounter, but if you do, the 2 things I want you to remember are the technique of holding the baby's head with your hand, the head between your hand, and if you can remember middle finger in the mouth for control. And the second one is holding the legs and bringing the baby all the way almost up over the top of the mother so the head kind of rotates in a way that gives it the best way of coming out. Those are the 2 things that I remember from way back that I wish I had known that night. I would have felt a lot better. Now that I put this on, I bet you guys are going to get reach calls all the time, which I can just see, Rel, you're going to get a call from some in the middle of the night. All right, any questions about anything we covered? Is there anything else you want to talk about tonight? Okay, good. I'm glad that you guys are. Yeah. Well, thanks for having me.